Good evening. Thank you so much for watching HealthLine on PBS Fort Wayne. I'm your host, Mark Evans. Great to have you along. We'll talk about a very important topic this evening, blood cancer, which has seemed to come to a topic of conversation and is trending because Tatiana Schlossberg, who is JFK's granddaughter, has been diagnosed with blood cancer. And we'll talk a little bit more about that during the show. But we're going to talk mainly to Dr. Matthew Bartock, who is a hematologist. We appreciate you being here tonight, and this is your first time on HealthLine.
Yeah, I'm excited to be here. Thanks so much for having me.
Are you nervous at all?
Just a little bit.
Don't be. Just pretend that we're having a conversation at dinner and people are eavesdropping and stopping by and asking questions. And speaking of which, that telephone number is on your screen, 866-969-2720. Call at any time in the next half an hour. We are public television. We don't stop down for commercials, so this next half hour is all yours. And I'd like to go ahead and start out. Of course, you have been reading about Tatiana and her diagnosis of blood cancer. How far along is she with this?
She's quite far along. She's been through what we call induction therapy, and she's received a transplant. So that tells us, number one, this is an aggressive disease. Mm-hmm. And then, unfortunately, it appears the disease has still come back. And, you know, at this time, it is not a great prognosis to have. Mm-hmm. I think that we do have ongoing therapeutic developments, clinical trials that, you know, may come along the line for her. Mm-hmm. But I do remain hopeful for this disease still.
Yeah, there's still hope. So, well, we thank you for being with us. And I'd like to start out by, as I do every show, talk about your specialty or your profession. You're a hematologist. What exactly does that mean?
Yeah, so I focus primarily in my practice is based on blood disorders and blood cancers. So blood disorders can be anywhere from anemia, low white blood cells, low platelets, blood clots. And then on the other hand, more aggressive diseases like blood cancers. Mm-hmm. And blood cancers is a very broad term. Mm-hmm. We use it to define any cancer that's derived from either the blood cells, the bone marrow where we make all these beautiful blood cells, or the lymphatic system.
Okay. So what is blood cancer? And I know that there's more than just one particular blood cancer, but what is blood cancer in general, and how many people are dealing with this on an annual basis?
Yeah. So there are, again, many different types of blood cancer. There are lymphomas, and there's two different categories of lymphomas, and we classify these as Hodgkin or non-Hodgkin lymphoma. We have leukemias, and there's many different types of leukemias. There's acute leukemias, such as acute lymphoblastic leukemia, acute myeloid leukemia, or more chronic leukemias like chronic lymphocytic leukemia or chronic myeloid leukemia. And then we go into pre-leukemic disorders such as myeloproliferative neoplasms, which affect bone marrow scarring or high growth of platelets or high growth of red blood cells, or myelodysplastic syndrome, which means irregularly forming blood cells within the bone marrow, which can be a precursor to leukemia.
You mentioned Hodgkin's and non-Hodgkin's. Can you explain the differences between those two?
Yep. So the differences are often determined by the types of cells we see under the microscope. So something called a Reed-Sternberg cell, and we use different biomarkers or stains to see these cells under the microscope. And when we talk about Hodgkin lymphoma, it's a very treatable disease, and in many cases can be potentially curable. And on the other hand, we have non-Hodgkin lymphomas, which there's over 50 different types of.
Wow.
And this can involve slow-growing lymphomas. Some, in fact, may never need treated, or it may take several years on observation before treatment is required. Or we have aggressive lymphomas that need immediate action, or it will result in bad outcomes.
Yeah. Well, and just amazing. And I just read, it was from the CDC, that 1.2 or so million people a year are affected by blood cancers.
Correct. We're getting better at diagnosing them. Also, patients are living longer these days.
Yeah.
So we are seeing more and more in our clinics, which is wonderful. I mean, I'm having an amazing ability to meet these patients and help them on their journey. So
the research is fairly aggressive on this.
Correct. We just had our largest blood conference, the American Society of Hematology conference, over this past weekend. There was thousands of abstracts, wonderful presentations, beautiful developments going on in this field.
Yeah, I have to think of any of my relatives or friends that I can recall. I don't think except for one, who has ever had a blood cancer. So is a blood cancer, if you rank those among the cancers, where would that rank? I mean, is it one of the more, I shouldn't say popular, but one of the most common?
Well, so it depends on at what age, you know. So blood cancers, when we talk about, you know, when is it most common? You know, for instance, childhood, you know, when we talk about acute lymphoblastic leukemia, it tends to be one of the more common childhood cancers. Many types of lymphomas, you know, can have what I call bimodal age distribution, where it can occur in the youth or it can occur in the elderly. But of course, this can occur out of that spectrum. And multiple myeloma, which is a different type of blood cancer, tends to occur in the more elderly population with an average age of diagnosis at the age of 69.
Oh, wow.
But, so we see any patients, I've treated patients 18, and I'm treating patients well into their 90s now with blood cancers.
Wow. So who's mostly affected by it and why? I guess if we're talking risk factors here.
Yeah, that's a great question. I can't say that there's any specific risk factor, but there are risk factors that are known. Prior chemical exposures such as formaldehyde, benzene, Roundup can increase the chance of blood cancers. I still see Vietnam veterans who have suffered from Agent Orange exposure and are ultimately diagnosed with blood cancer years later. Prior radiation exposure, I took care of a wonderful man who was on Marshall Island during atomic bomb testing.
Oh, wow.
Also, you know, unfortunately, chemotherapy can lead to different types of blood cancer. So it's kind of a double-edged sword. Certain viruses can increase risks of blood cancers, such as HIV or Epstein-Barr virus. But for most of my patients, the identifiable cause is not there. There is no different course of action that could have prevented the disease from happening. Is a random act of error.
Wow.
So think about the bone marrow as a factory, and in this factory we're making 500 billion cells a day. That's a lot of machinery to keep working, and at some point that assembly line can go awry, where we don't fix an abnormal cell and that cell starts to propagate or grow uncontrollably. And
is smoking a contributor to this?
It is unlikely to be a direct contributor, but I think that smoking, elevated BMI or obesity can increase the risk. There was a wonderful gentleman back in the 1930s named Heinrich von Warburg who discovered cancer cells thrive on sugar. Now fast forward to the PET scan, and the PET scan, what does it use? It uses a sugar with a radio label on it, and when exposed to radiation, it lights up where cancer is. Now if we take that forward to the ongoing obesity epidemic, I don't think this is coincidence. I think that in some cases, this may drive and fuel cancer.
Can you inherit it?
Possibly. So we have gotten a great understanding at how breast cancer, colon cancer, some genitourinary cancers are inherited. Blood cancer, it's estimated that maybe 5% of indolent or slow-growing lymphomas may be inheritable. There may be some genetic mutations that patients are born with, which may increase their risk, and we need to screen these patients appropriately. That's why it's so important to establish with a primary care physician to know your family inheritance and you know what diseases run with my family. And if we have 5 cancers in very close family members, we should get that looked at, and we should maybe see a genetic counselor.
Well, hinging on risk factors, we do have a call from James. He prefers to be off the air, and that's fine because we'll transcribe your question, and we do encourage your questions because that's what this show is all about. But James wants to know, is there a correlation between blood type and blood disease?
That's a great question,
Isn't it?
James.
Yeah, that is.
Yeah. So we have several different types of blood types, and when I think about the blood types, it's no direct correlation towards leading to a diagnosis of cancer, but we do use blood types very commonly for things like a stem cell transplant, and that might accept a better donor by having a matched blood type. Certain blood types may have some abnormal proteins, such as von Willebrand, and that's a different type of benign bleeding disorder. I guess it can be aggressive in some folks, but there's no known correlation to my knowledge of blood types and direct link between certain blood cancers.
Okay, and I'm sure the research is continuing on that.
Absolutely.
As well as the genetic side of it as well. So let's get into the signs and the symptoms of blood cancer. Does it take a while for these symptoms to arise, or are you going to wake up one morning and go, I wonder if I have blood cancer? How does that work?
Great question, Mark. So in my patient population, I've had patients who come to me completely asymptomatic. They just saw their primary care physician and their blood work looked very abnormal. And I've had other patients that I've seen the same abnormalities on them for 11 plus years before they're referred to me, and I do an evaluation and find cancer. So again, going to the indolent or slow-growing cancers. In some patients, these symptoms may be more aggressive, and the most aggressive symptoms that I find in my population is what I call type B symptoms, B as in boy. And this refers to drenching night sweats, unintentional weight loss, which is defined as 10% body weight loss in 6 months without trying.
Wow.
And drenching night sweats. So these aren't the type of sweats where you get a little sweat on your brow. These are the type where you can wring your shirt out, you got to go take a shower. Other symptoms that patients may have that bring them to a physician or the hospital are abnormal bruising or bleeding issues, kidney failure, abnormal electrolytes, which again, these would be tested for on blood tests, debilitating fatigue. But again, a lot of patients, depending on the type of cancer, may not have any symptoms, or these symptoms may arise abruptly, and that depends on what type of disease it is.
Well, then if they don't have any symptoms per se, as we've discussed, how does a physician figure out that, hey, we might be onto something? You might have blood cancer. Is that through a blood test? Is it a certain platelet check, or what happens there?
Yeah, great question. So typically when a patient sees me or sees a primary care physician, they're getting some evaluation, whether it be a wellness check and they're just getting a once-a-year blood count check and a metabolic panel. In other patients, who are presenting with symptoms, yes, we kind of direct the workup based off of what symptoms they're having. If they're having bleeding, yep, we're going to check a CBC. We're going to check some coagulation studies. We're going to see what medications they're on. But once we find, the initial blood work and we see what we're leaning towards, are we leaning towards a lymphoma? And yep, I see a large lymph node on the exam, or I'm noticing, the patient's having a lot of weight loss and we need to maybe do CT scans. So we'll start with some CT scans to find out where else the lymph nodes may be, and do we need to do a biopsy? In some cases, we see low blood counts and we may do an evaluation. We'll find iron deficiency and we replace the iron, and the hemoglobin, the red blood cells, go back to a normal range. But if we do this evaluation and we still can't find an identifiable cause, oftentimes we'll have to proceed with a bone marrow biopsy, which it is an outpatient procedure. It involves having the patient lay on their stomach or their side, and we'll clean them thoroughly. We'll numb their skin with lidocaine, and we'll use a needle to get a very tiny sample of the bone and a sample of the fluid within the bone.
Where does that go? In your chest? Or?
So we can't do them from the sternum, for obvious reasons, the heart being right behind that. We do our best to not do that these days.
Okay.
The most common place is the back of the hip.
I see.
And once we get the sample, we send it to pathology. They look at the sample under the microscope. We look at certain stains, and most importantly these days, we're looking at drivers or mutations of the disease, which we're learning how to target.
What causes the drenching night sweats, the fever? What would trigger that if you had blood cancer?
Another good question. It could be potentially the underlying burden of the disease. When we think about aggressive blood cancers, we're actively, rapidly dividing blood cells, and even some of these blood cells are dying in the process. So that can unleash a storm of inflammation within the body, leading to sweats.
Okay. So you might have, or you may not have blood cancer. We don't know. You go in to see your primary physician, but there might be some suspicion. So how is blood cancer going to be diagnosed?
Yeah. So blood cancer, and oftentimes this can take some time to diagnose. I've followed patients for a couple of months, and we're gradually piecing the puzzle together. And some patients, where we don't have that time, we have to bring them into the hospital to get an urgent biopsy, whether it be of a bone marrow or a lymph node, and at least stabilize the disease.
All right. So we're talking blood tests, or are we talking any type of imaging tests that might be required?
So for more aggressive leukemias, we often don't need imaging. We may need some specific imaging of the heart based on what type of therapy we're giving, because some therapy can affect the heart.
Okay.
If it's a lymphoma, we often will need CT scans in order to stage the disease. In some cases, we can actually diagnose the disease based off of the blood work alone, which is wonderful. But in most cases, in lymphomas, we are doing imaging to establish a staging system, if you will.
Now, when I go to the physician on an annual basis, sometimes a little more often than that, they want to feel my neck and the lymph nodes. Is that one of the reasons? So they're trying to figure out if there's a possibility of blood cancer, or what else are they checking for?
Correct. I mean, there's a lot going on in the neck. We have blood vessels, we have arteries, veins, nerves, the thyroid, and of course lymph nodes. So we have lymph nodes throughout our body, but the most easily found lymph nodes are in the neck, above the clavicle, in the armpit region, and then in the groin region.
Okay.
So in all of my patients, when I have concern for lymphoma, I'm doing these exams to see, can I feel anything? Is there anything that I should specifically dedicate my imaging towards?
All right. We still have plenty of time to go on HealthLine tonight. The telephone number is 866-969-2720. If you have any questions regarding blood cancer, we're talking to Dr. Matthew Bartock, who is a hematologist. So, is there any way, and you talked about these, but I'm just really curious to detect, and you said there are some times that it takes a while to detect whether or not you have blood cancer, but is there any way to detect it early?
At this time, unfortunately, no.
Oh.
It is my hope that with time we'll be able to come out with those factors, but we don't have a mammogram which can detect early breast cancer or colonoscopy to detect early colon cancer for blood cancers at this time.
Or a particular blood test that says, yes, you have blood cancer or you don't have blood cancer.
Unfortunately, at this time, there is not.
You would think that there might be, and I'm not slamming the medical profession, but it's just one of those quandaries out there. It's just, that's just amazing to me.
That's why, again, I think it's so important if a patient has an ongoing lingering symptom that, again, we need to have some trust in our medical providers and seek help.
Yeah, certainly. So we're talking about diagnosis and talking about the risk factors. So how are blood cancers treated?
Great question again. So we can do a brief overview of each individual therapy and then break it up more into disease site-specific therapies.
Okay.
But we have many therapies available, and one of the most common that we think about is chemotherapy. And what does this do? It kills fast-acting, fast-dividing cells. And it does tend to have many off-site effects as well. It doesn't discriminate after these fast-acting cells. We have targeted therapies, so we've gained knowledge about how to find a mutation, and we've developed pills in some cases to target these mutations, like chronic myeloid leukemia. Before the 2000s, that was a very grim prognosis to have. Now we have a pill that patients are living long, almost normal lifespans on these drugs. We have immune therapy. So we are learning how to engage the immune system to go find and kill cancer. So there's a chance that in my body right now I have a cancer cell, and my immune system recognizes it as bad, foreign, you shouldn't be here, and kills it. Cancer can be sneaky. It can evade the immune system. So we're finding ways to re-engage the immune system to go find and kill cancer. We have antibody-based therapies, and antibodies float throughout the blood. They're trying to find something bad to bind to. And once it binds to something bad, it signals the immune system to come on and kill it. We have drugs to do that against some cancers. Radiation therapy can be used. Bone marrow transplant is also used in certain types of blood cancers, such as multiple myeloma, leukemias, and lymphomas.
The bone marrow transplant has always been fascinating to me. How does that work?
It's an absolutely fascinating procedure. So I am not a transplanter, to be clear. But there's two main types of bone marrow transplant. There's autologous, what we refer to as auto stem cell transplant, and this uses someone's own stem cells. So what we do is we get the disease into remission, and then we collect these stem cells. And again, the stem cells are important cells because they can divide into any one of the blood cells, the red blood cells that deliver oxygen, the platelets that prevent us from having bruising and bleeding issues, and the white blood cells that hopefully prevent infections or fight infections.
And that's the big one, right?
That's the big one. So once we have the disease into a good spot, a good remission, we give extremely high doses of chemotherapy to the point where it may take months for the patient's bone marrow to recover to make their own blood cells. So after we give that chemo, we come and rescue them with their own stem cells. So they make their way back to the bones and start to grow again.
I see.
Now, on the other hand, there's an allogeneic stem cell transplant, which uses someone else's stem cells. And in some cases, we can use a family member's, a child's, or what we call a MUD, or a matched unrelated donor. And The thought that we can still give high chemotherapy is still there, and we rescue them with stem cells, but it also provides something called graft versus host disease, so where the donor cells can attack the recipient's body. So this can affect the skin, the lungs, the gut, the liver. But we have found that patients who do have a little bit of graft versus host disease, they actually fare to do better. The reason being that if there is any residual cancer cells left, that they may recognize them as bad as foreign, and the donor cells can go and kill them. So it actually improves survival.
So I guess what I'm reading into, blood cancer is not necessarily totally curable.
Some of the blood cancers are absolutely curable.
Okay.
We can never guarantee a cure in cancer, but some types of lymphomas, leukemias are absolutely curable.
Good, good.
Now, when we think about diseases like myelodysplastic syndrome, again, potentially be curable, but not outside of a transplant, but treatable outside of a transplant. Multiple myeloma, we have over 12 different therapies these days for these patients. It is a disease that we can live with for often many years. In some types of indolent or slow-growing lymphomas, most patients, who have like chronic lymphocytic leukemia may not need treatment up front. And we can often observe the patient with labs and exams every 3 to 6 months, and they can go years sometimes without needing treatment. And that's often difficult for patients and families to understand. So I like to explain it as follows. If I'm in the Army and I'm going to war, and if I spend every bullet at the range, I'm not going to have anything to fight with when I really need it. But to further that, there's been studies that show that early treatment does not improve survival. So do I want to bring a patient symptoms from therapy and not change survival, or use a line of therapy that we could have used down the road for their disease?
So if it's not entirely survival, in other words, you wouldn't be able to survive it completely, you could still elongate someone's lifetime.
Correct.
And that's great because of the medications and because of the treatments we have available.
Correct. And some of these diseases, I'm again treating into the 90s, and the treatments these days can even involve pills this patient takes at home.
Yeah, that's great. So how can you lower your risk?
Great question. Lowering the risk, I think, again, exercise, maintaining a healthy, natural as possible diet. I can't necessarily say organic because it's not sustainable these days. I think trying to avoid excessive uses of alcohol, trying to avoid smoking. And I think the biggest thing is establishing care with a provider you trust, and who's going to follow through on what symptoms you may be experiencing.
And you mentioned smoking. What about secondhand smoke? Should you try to stay away from that as much as possible too?
Absolutely.
Okay, very good. You're the man. You're the man. All right. So if you have blood cancer, is there anything that we can do as family members, friends, and so forth to help support, to help these patients, and what challenges do these patients actually experience that we may not be aware of?
Yeah, I think my patient population has many challenges, and this can be from the burden of the disease, and that could be bruising or bleeding issues, fatigue, that could be debilitating. Some of the patients, can't have ride assistance. I have some patients, or some blood cancer patients are coming to clinic 1, 2, 3 times a week to get blood checks and possible transfusion support. That's a lot of caregiver burden. The financial burden is immense, and it's not just from the treatment, but it's from the lab checks, the rides to and from. In transplant patients where we have to live next to a transplant facility for up to 100 days, that requires housing support.
Yeah.
The paperwork is immense, from insurance papers and bills, and if anyone can help out with that, that's fantastic. Same with the rides. We're cooking a meal for them, shoveling a driveway. A little bit can go a long way.
And to support them, to help them as much as possible, and to try to relate to what they're going through and how they're basically feeling. They're probably not feeling all the best when they have blood cancer.
Absolutely. I think the energy level is down. There's a lot of fear of the unknown. There's anxiety, there's depression, and just being a friend, listening. You never know what someone's going through.
Yeah.
And to further, what else we can do, I think blood donations are extremely important, and absolutely I support giving platelets or giving blood. or even signing up for the bone marrow transplant list.
Yeah.
So there is a website, NMDP, National Marrow Donor Program, where you fill out a little bit of stuff online, and they send you a mouth swab if you qualify, and you could be a potential donor to save someone's life.
That is great stuff right there, Dr. Bartock. Thank you so much for being here tonight.
Thanks for having me.
And we have to have you again, okay?
Absolutely.
Thank you very much. And remember, you can watch this episode as well as other HealthLine programs on YouTube. And we thank you very much for watching tonight. And we thank you for your calls, your questions, and we hope that you have a wonderful holiday season. Until next time, good night and good health.
PBS Fort Wayne was made possible in part by
Momentum, progress, innovation. Parkview Health knows standing still isn't an option. We must learn, grow, excel, and actively work to advance healthcare for our community and beyond. With technologies that improve access to care and teams of specialized providers, we are moving healthcare forward. Right here at Parkview Health.